looking at today is the new maternal serum blood tests that are coming out regarding moms and pregnancies. How many are familiar with the new tests that are hopefully going to be talked about today regarding free fetal DNA in maternal serum, or have heard some things about it? Some have, okay. So this was a thing that hit the press this year, and it was June of 2011 in the Star Tribune in Minneapolis. And the quote from this paper in their Understanding New Maternal Blood Tests was an article written by Malcolm Ritter, Associated Press, looking at new earlier blood tests for Down syndrome pregnancy may bring women comfort or conflict. And what was key about this article was they had several women in there who had waited until they were 16 weeks or waited until they were 20 weeks for their targeted ultrasound to look at, do I have a higher risk for fetal aneuploidy or not, because I'm now over 35, which in my practice is a growing phenomenon as people still continue to delay pregnancy for success in life, which I think is appropriate and inappropriate, as some of my patients who are 42 and 45 will tell you, as they have hypertension, diabetes, and have difficulty getting pregnant once they decide to start getting pregnant. And what this article was talking about was the tests that are being developed right now to extract fetal DNA, circulating free fetal DNA from maternal blood in order to assess the ploidy status or aneuploidy status of that, as well as gender of that from the free blood in the serum. And what the article stressed was this woman's problem with facing amniocentesis. As she faced amniocentesis, she still underwent the amniocentesis when she was about 17, 18 weeks of gestational age. But when she found out that baby had trisomy 21, she had, quote, as her own quote in the paper was, already felt the baby move and made a decision not to do anything about the fact that she had a baby with trisomy 21 other than inform herself of what other things need to be evaluated, who to see, etc. So there was a little bit of concern in this article that long before women feel baby move or that they bonded to pregnancy, there will be tests available, and these tests are coming out. Our site, Dr. Tracy Prosen, one of our MFM geneticists at our site, is currently extracting blood from moms as part of one of the national and international studies, extracting blood from moms in order to assess at the time that we do CVS or at the time we're doing amniocentesis, can we extract free fetal DNA from their blood. And what we're looking at is free circulating DNA. What do we know about it? What do we know about this stuff? We know that around 10 weeks of gestation is when we can start seeing free circulating fetal DNA. It's usually nucleic acids. But what we can see is that at around 10 weeks gestation. And why does it end up that way? And then I'll get back into my slides in a second. It ends up that way because we know from all the new work on preeclampsia, if any of you have been keeping up on preeclampsia, and I usually give that talk here, we know that the placenta has to dig in, and it has to dig in appropriately, and the maternal syncytial trophoblasts have to recognize the baby as foreign at 10 weeks gestational age. At that gestational age, when it recognizes that foreign, it allows the fetal tissue, the placenta, to interdigitate into the spiral arteries and make them into veins. Okay? Why does that happen? It makes it into veins so that no matter what happens to mom, she can't squeeze the placenta off and kill the baby. Now, is that a good thing or not? Well, if the uterus doesn't contract down, that's the only thing that stops bleeding, mom dies. But if she doesn't have any children, the human race disappears. So the goal was to keep that supply open so that interdigitating is when that happens. That's also the time at which we start seeing this stuff floating around, the debris from babies, into mom's circulation. That's because there's an establishment at that time of a communication. I was taught very little other than substances like liquids and things like that, ions, etc. Very little cross the placenta to baby, or to mom, I'm sorry, the other way around. And now that we know more and more about this, we're starting to learn that there's a lot of stuff floating around in mom. And so what do we have when we try to look at this? Fetal DNA has been found in maternal tissue in cardiac transplant patients when they've removed their heart and they've given them a transplant and they look at their heart and examine it. They have found documented tissue, or cellular, I should say, DNA from their prior pregnancies sitting in their heart, and it may be 10, 15, 20 years later after they had their last pregnancy that this DNA lives with them forever. She becomes a pseudo-chimera in a way because she's carrying around DNA in her tissue that seems to last for a lifetime. When we look at maternal serum DNA, or nucleic acids, as we probably should say, when we look at that, that doesn't last as long. It shows up, as I said earlier, in the blood in quantity around 10 weeks gestational age. And so when we look at that, you can't test earlier than that at that point in time because you wouldn't see the tissue there. And when you look at studies where they're first trying to extract this, they took it from sources that would have very high content, hopefully high content of that, into mom's serum. So they used people who were undergoing terminations with oral or vaginal cytotech, who would have violent contractions of the uterus and maybe express into the maternal serum more high concentrations of fetal DNA. So there were kind of a group of patients who, again, felt they were gaining something being part of a study, but also showed us that things like disrupting the placenta, the contractions of it, maybe the fact that the uterus isn't totally emptied at the end of it, increase the ability of the quantity of DNA that could be extracted from these patients. What's really neat is it disappears. The free DNA in mom's blood disappears very rapidly after birth. By about 4 hours or so, there should be nothing there. And in the first 30 minutes, the bulk of it is cleared from mom's system. So what this implies to all of us is that there's a constant showering during the pregnancy of this DNA. And when you withdraw the source, i.e. mom delivers vaginally or mom ends the pregnancy, then the DNA stops circulating around and gets cleared. And this is the free DNA. Again, tissue DNA or cellular DNA stays a lot longer. At some point in time during pregnancy itself, it makes up 3 to 6% of the total DNA circulating in mom's circulation in her plasma. And so what's interesting is, just like the original studies where they used it on people undergoing termination, as I mentioned, Dr. Prosen at our site is serving to collect data for research looking at what do we get if we do it after an amniocentesis, what do we get when we do it after a CVS. So in practice, when people start talking, are we running this into practice, most people believe that's coming, and it's coming shortly here, that you'll be able to actually get these nucleic acids from it. And again, the source most likely is placental in origin. When that comes, we'll be able to have a diagnosis earlier. But again, we don't know how it's going to run when we're drawing this on massive numbers of people, and we don't have procedures going on. Because like I said, the studies we're doing is right after CVS, they go down and get their blood drawn. Right after amniocentesis, they get their blood drawn. So if you look at CVS, there's a huge disruption of the placenta as they're doing the CVS procedure, must amplify the amount of DNA that gets across. Amniocentesis, they see a much more mixed picture. If you look at Diane Bianchi's work, much more mixed picture on how much DNA is actually getting across, and probably whether or not you had to cross the placenta or not, versus just going through the membrane and less exposure. So it's seen a quantity at 10 weeks, disappears in 4 to 6 hours, and it's 3 to 6% of DNA. Currently, there's 3 companies, and this is from the same article, 2 in California and 1 in Germany, that are hoping to have commercial product by the end of this year, so this will be coming to us. It's a California-based test, are performed around 10 weeks gestational age, and again, their data was taken from women who were undergoing termination earlier. German-based testing was performed at about 12 to 14 weeks gestational age. Results for both come back in 7 to 10 days. So, as I said, the tests that we've been doing, or at least my partner, Dr. Prosen, has been doing in our practice, one of my 6 partners. Current clinical trials include blood draws around these tests. This disruption may be increasing around, and it does that, and I'm not sure it will or not, does it have an impact on free fetal DNA? And we've recognized for a long time, Diane Bianchi and a group who's been leading this in the US for a long time has recognized that we see for patients who have trisomy 13 babies and patients who have trisomy 21 babies, we see definitely higher levels in their serum of their free fetal DNA. We see less of that with the trisomy 18 babies. So, what affects levels also, and I found this interesting, I think when they start talking about shotgun sequencing things, looking along your whole genomic code and try to picture replication repeats along that sequence and associate with disease, which we'll talk about at the end. My last slide, I'll go off on a little tangent. I think what you'll see is things disrupt and change levels of this DNA. Smoking increases total maternal serum cell-free DNA levels. And so if I'm correct, that a lot of this, and Bianchi's obviously the one who hypothesized this, that most of this comes from this interface with the placenta, it suggests that there's increased cellular death in those women who smoke, hence we see more IUGR, hence we see more preeclampsia. So everything we clinically saw is coming back to haunt us with what we see. And I don't know how that's going to go over when you start telling patients, well, now we have data that if we go and draw your blood, we get more free DNA because you're wrecking your placenta. I don't know how that's going to go with women, especially if they have a bad outcome. And then we carry that burden the rest of our lives that my doctor told me that. But I can hear that coming if all of you can't. I see it's coming. Non-smokers at 90, PCR measure of free fetal DNA. Smokers, 97,662 genome equivalents per mil. Non-smokers, 38,217, almost 3 times the amount in the people who smoke, 3-fold higher levels than non-smoker. Maternal age and synthroid youth were slightly different between the two groups, and the ones that were smoking were also older, which I think might have been part of a generation. That is, hopefully that's going away because I'm starting to see less and less smoking. I wish I could see less meth, crack, crank, and all that other stuff, but I can't get rid of everything at one time. So, understanding the new maternal test. So what are the social concerns for this? Previously, all we've ever had is a screening test. And remember that, that's all we've had other than the definitive test, the amnio or the CVS. The CVS, where I talked about disrupting the placenta, remember it's also been associated, early CVS, with a higher risk of women developing preeclampsia later in pregnancy. Not many people tell patients that, but there are some studies out there that have looked at that and said, you know, if you go in there and disrupt too much of the placenta to get your data, you may cause more problems later in pregnancy. Social concerns are the triple test and the quad test and first trimester screening. While each of those, as they continue to advance, especially the big change in the quad test compared to the triple test as far as detection, both the idea of sensitivity and specificity was markedly improved in the test. A very well-established test with more than 80% ability to pick up those kids that have trisomy 21, 18, or 13, as well as look for spina bifida. A very stable test that's been around for time and has been used a lot. Part of the problem with it, as we'll talk about in my last slide, is patients misinterpret what we tell them about the quad test. I'm amazed at the women that I see in the office because someone saw a little white dot in the heart on their targeted ultrasound at 18 weeks, which I frankly voted in 2003 on a panel for our society to say, let's not tell women about that dot anymore. I'm sick of hearing about it. And that, you know, you go into the room and you tell that woman, here's a little dot in the heart, but your quad test says your risk is 1 in 10,000. Oh, I'm sorry. And maybe even 1 in 15,000, depending on the lab. And the patient says, okay, I'll have the amniocentesis. And then you go, okay, do you understand 1 in 15,000, 1 in 10,000 versus my rate of 1 in 200 to 1 in 1,000, depending on what you want to quote for your rate of loss. And the patients just say, yeah, I want to have the test. And it always makes me a little bit nervous because I'm not sure they can do the math or they understand the math. And so when I get done, on my last slide, I usually talk a little bit about the fact that everybody's always quoted as saying, I hear this all the time from grandma in the room. I started to call her grandma, but she will be because her other daughter had a child, and now she's having this one with her new daughter, with her younger daughter. But I always love how grandma says, they told my first daughter that her baby had Downs. Her doctor, her OB-GYN, always blame the OB-GYNs. I love that because I'm an OB-GYN that did 2 years of a fellowship. I got the short route, it wasn't 3 at the time. So they love to say, my doctor told me it was, and you know that baby never had Downs. Well, then I go back and I go, well, do you know what the numbers were, ma'am? No, they just told us it had Downs. And then you go back and look and you realize their risk was 1 in 3,000. Well, gee, without doing the amnio, I could have bet on that and done very well in Vegas. So I hear that all the time, and people misinterpret tests. So one of the things that may be nice about this test, it should be a yes or no. Do you follow me? Instead of just your risk is, because I don't think people understand risk. When you look at studies done on patients understanding how data is given to them, if you give them a fraction or you give them a percentage, they do not understand it universally. It's almost 75% of them misinterpret what that means. When you say your risk is 1 in 10,000, they don't understand exactly what that means. They don't understand when you say your risk is less than 1%. They don't understand what that means, and they misinterpret that simply because of whether it's an understanding of the actual test, whether it's the fact that they're pregnant and nervous and they want everything to be perfect. And what freaks me out all the time is I'm dealing with someone who has a 1 in 10,000 risk for Downs. They want an amniocentesis. And when I say to them, do you realize that 10% of citizens in this country, and you remember them from grade school when the teacher would say in 4th grade, read Johnny, and Johnny would go, okay, Susie, why don't you read again? And Susie'd go on for pages. Do you remember that? That happened to me. I was the bad reader, and Susie read better than I did, so she always went ahead. And so some of us, it's harder for us to understand what these tests mean, and I think it gets very confusing. So one of the nice things for the testing would be this would say yes or no, your baby does have this problem, or if it's a gender-specific thing, let's say a disorder genetically that should affect only males, you'll be able to tell them it's a male or not a male. Maybe they won't want all the other information on the chromosomes and that. That becomes, again, a very personal choice. Just like the woman who does have the 1 in 10,000 and I have a negative targeted ultrasound and I'm pushed her out to 1 in 15 to 20,000, if she wants the amnio, I ultimately do it because, again, that's her choice. So our previously, the triple, the quad, and then the first trimester screen or combinations thereof. And as you guys are aware, the first trimester screen pushes out in the 85 to 90% detection rate combination of the nucleotranslucency and serum markers. And as you know, we have learned a lot about serum markers. Serum markers not only tell us is there increased risk, as I said, for chromosome problems, they also, like unexplained alpha-fetoprotein, abnormal PAP-A value, explain to us or at least recommend to us that we may have higher risk for adverse pregnancy outcome involving placentation and preeclampsia, etc. And then targeted fetal ultrasound, as you guys are aware, maybe 2 out of 3 kids with Down syndrome actually would have something you'd see on ultrasound. Trisomy 13 and 18, more likely to be in the 90% range, but again, not very good. And waiting for 20 weeks, there's a lot of difference between that and the patient who's sitting there early in pregnancy having a blood draw at 10 to 12 weeks and the bonding with it. So when we look at trisomy 21, and this is Dr. Scotto, who is from Children's Hospital in Boston, who deals with children with Down syndrome, stated that there's, as a reply in this article that was run in our local newspaper, 6,000 children are born with trisomy 21 each year in the United States, 1 in 691 live births. And because of what we've been doing for surveillance, 1989 to 2006 fell 11%, while expectations were it would rise 42% over the same time period. Why? Because women became older as they were delaying childbearing, because we told them, everyone who grew up in the 60s told them all, have your kids, right? Have your kids when you're older, get through college first, etc. Not always the best recommendation, but it does make you guys a lot of Clomid dollars out there getting those little engines to fire up. So it fell over time, as we can see, on the live births for Down syndrome, and that obviously follows with screening, even though the age of the population went older, suggesting that screening for those patients who desire it did have an impact. So what are the advantages of this? Serum fetal DNA would give you fewer false alarms. It still does. It would hopefully, the big goals when Diane Bianchi has been doing all of her research in this, and she's actually the expert on this, really goal was to try to have fewer risky invasive tests. The ultimate goal for any screening test would be that it doesn't carry a risk. And so if you can draw mom's blood and you can find this information appropriately and not have too many errors in your lab, it'd be a nice replacement for the patient. The information is given earlier, And one of the concerns that the expert on Down syndrome has is that when we give this test earlier, we are having patient have no fetal movement. She's not necessarily bonded with the patient. Her partner and family, which makes it nice for if she does choose to end the pregnancy, doesn't have to know necessarily at that time. I'm not sure that's so good in my patients who have real close relationship with their spouse or partner. I'm not sure that that always is necessarily good because they probably should be part of making the decision, because every time my patient tells me, I'm not going to tell them, I'm just having the amnio, that's the one who usually miscarries, and then she's got to tell them she miscarried, and then she feels guilty and tells them she had the amnio, and then you know where that relationship's going. And so that one always makes me a little bit frustrated. And it may make it easier for those patients to have it earlier simply because they don't have to tell all the relatives, they don't have the little bump yet. It may make them easier in their decision making because there's a lot of societal pressures. The concern that he had, or his, as an expert who cares for kids in Boston with Down syndrome, was that in the case of Down syndrome, many women may be getting bad information. And I think that's important. I have a son, Chase, who is 18. All three of my boys are 18. They're triplets. And they all graduate except for Chase this year. Chase has delay from being early. He doesn't have a chromosome problem. He just has developmental delay and mild CP. And I got to tell you, it was always so frustrating to me when I go to the special needs kids track and field day when Chase would get whipped by all the Downs kids. So I didn't understand what the problem with Downs was because Chase couldn't keep up to him. I'd have to run with him and hold his hand. But as Dr. Pincus in the back of the room will say, I was a little heavier then. I'm trying to lose some weight and get in shape. But we always got beat by the Downs kids. And I realized having the kids with special needs is a big burden and is difficult in life to manage. But I think it's important because what he quotes is several studies that report that medical students have very little, if any, training in how to deal with kids who have special needs or Down syndrome itself specifically or other disabilities. We're not taught really how to deal with people with disabilities at all. So Eric et al. Did non-invasive. So where did we all get started? Non-invasive detection of fetal trisomy 21 by sequencing DNA in maternal blood, 480 samples in patients who were at high risk for trisomy 21. Trisomy 21 was found in 40 patients. Euploid were matched at a 1:11 ratio. And when they looked at this, 13 had insufficient quantity, 18 had failed qualifying controls. And this was the first look at trying to bring this stuff out when you look at Eric's data from when this test was starting to be developed. Samples that remaining were 449. 39 of these were correctly classified as trisomy 21. One was misclassified as trisomy 21. So we need to keep in mind, while sensitivity may be better with this test, because obviously it's looking for it and will maybe find it, specificity still will not be 100%. It's hard to get any test that's 100 and 100 in any category. So there's going to still be the occasional patient who will say, I got the wrong result. Engert in 2003 looked at cell-free fetal DNA in the cerebrospinal fluid of women during the peripartum period, worked with Dr. Bianchi, who's been doing all this work, and I think they said, do you know what? They're probably watching the spinal being put in for a section and said, I wonder if we can't get some of that fluid because it's right there and let's run it. Because I can't figure out why else you would do this, because if you can draw it from your blood, why would you be looking at your spinal column? But I like the novel idea of saying, since we've got the fluid, we might as well run the test. I thought that tells me a little bit about the researchers. Kind of think like I do, kind of crazy in the head. So 39 women, and they had to have in there, if they were twins, at least one male fetus in the conceptus in order to identify it. Female fetus only, and that was 26 of them. Fetus N equals 13. Results, the beta globin DNA was detected in all CSF samples. DYS, one gene sequences in 4 women, not in all of them that had the male, and no male DNA were found in women with female offspring. So not perfect, but started functioning as a test to look for just, again, gender, specifically for gender disorders. Fetal red blood cell typing, Rh positive or not, genotyping detection from circulating cell-free fetal DNA in maternal plasma by Bombard. 207 patients, 201 were classified correctly. The test has accuracy of 97.1%, sensitivity of 97.2%, and a specificity of 96.8%. Why is this important? Because currently, as we know, if a mom is sensitized, we can have dad check for his genotyping regarding his Rh status, and is he heterozygote, meaning he only carries one gene positive, and the kid therefore has a 50-50 chance that it doesn't have Rh positivity, which will turn mom on to attack it, or does he carry both genes for it? Do you inherit from two parents? And it's 100%. If it was the 50-50, you can then offer that mom at 16 weeks or so, if you know his genotype, and it was 50-50, you can offer her an amniocentesis to test the fluid around the baby and get the DNA and see if baby is Rh positive or not. If it's not, no one cares if her titer goes to 1 to 16, 1 to 32. It's not going to affect the baby. If it is, then she is the one who may end up with Dopplers frequently, may end up with a PUBS later in pregnancy, etc. Titers rise in subsequent pregnancies, even if the baby's Rh negative, through some sort of amnestic response or memory response that moms have. And unfortunately, some of those women go all the way through to the point of MCA Dopplers and testing very frequently, or serial amniocentesis in some centers throughout the pregnancy would only increase her risk of becoming more and more sensitized if baby is Rh positive. So 207 patients, 201 correctly done, test inaccuracy 97.2%, specificity 96.8%. So how did we get here, and how did we get all this way along, and who's done all the work? Welkanowska, 1969, took 22 patients with no and male fetuses, used lymphocyte mitogen to extract 46 XY cells from 19 of the 22 patients, was able to get out. This was the starting pioneer work of saying we can extract out the male cells from the mom and start to identify that. If we can do that, we can go on to bigger and better things. Herzenberg, 1979, fluorescence-activated cell sorting to enrich the number of fetal cells in maternal blood in order to gather enough of them to do your studies on, because they are relatively few and far between when compared to maternal cells and maternal DNA in blood. Diane Bianchi enriched fetal nucleated erythrocytes in maternal blood using monoclonal antibody to CD71. And Eric in 2011, again, multiplex massively, parallel shotgun sequencing assay for trisomy 21. A lot of things, but basically shotgun sequencing across the DNA spectrum, looking for patterns and repeat segments that may suggest different disorders, such as Down syndrome, such as other disorders we'll talk about in my comments at the end. And this is circulating cell-free DNA again. And remember, as I said, falls off within an hour massively at the after delivery. A facile, as Lee Schulman, whose whole interest in life is genetics and management of patients with genetic disorders, and in families where there's horrible genetic disorders, has been part of the pre-implantation genetics program that they had at their institution. Stated that the whole goal had been a facile, economic, and more accurate approach to prenatal screening and an effective, non-invasive alternative to invasive prenatal screening. And I was surprised he said that, because sometimes I look at he and some of his colleagues, even though I've worked with them on committees and stuff, sometimes I look at them as all they see is everything's a genetic disorder, and I always get much chagrin when I hear a partner of mine telling a patient, oh my God, on your ultrasound, the head's really narrow. Do you know that's dolichocephaly? And the patient goes, I thought a big wide head was bad. Oh, that's true. A brachycephaly head or brachycephalic head might mean more Downs. But look at all the syndromes that have dolichocephaly. Guess what? They told us that about all three of my boys. They got dolichocephalic heads. I go, and? And I'm looking right at the person going, and? So did I. My mom said I delivered very easily. Thank you. You know, you got to take everything a little bit with a grain of salt. But they were, and I like this idea that this is what he's been thinking about all along, is if we can find a better test, we won't scare so many women. We'll hopefully do less procedures, which result in, obviously, losses. So, in my mind, in conclusion, the technology is surpassing our ability to keep up clinically. We know that in some of the work, like I said, with Bianchi, that 13 and 21 have markedly higher levels. We don't always see higher levels in the blood for moms, so it makes it hard to detect for 18. It's going to change our mindset. No longer will we be talking screening tests, and I think this is coming. I think it will be coming in the next several years, about risk assessments, et cetera, based on age or not. I think you're going to have patients that are still going to say to you, and I love the patients who walk in and say, you know what, I don't want anything done, just tell me it doesn't have 2 heads, and they know what they want, or they walk in and they say, I want the amnio. The most frustrating patient for me, as I'm sure is for you, when they have a super low risk for them to sit and hem and haw for weeks and not sleep and finally end up coming in and having an amnio when they maybe now have a risk of 1 in 20,000 and you yourself don't feel like you really want to do it, but you end up having to do it. And that's the most unfortunate one, and I had that a year and a half ago, who went back home and 4 days later fevered and lost her baby, and her risk was virtually, in my mind, non-existent. But again, that was my opinion. Marked changes in our client set. Bonding may or may not have occurred. I don't know how important that is. I think for some patients, the bonding has changed. I have patients that tell me once they saw their baby on ultrasound, they wouldn't do anything about it. It's the studies that came out of the abortion clinics that if you showed them a picture of the baby, the moms were less likely to proceed with the abortion. There's a lot of different things that impact what's going on for mom. It's a horribly, horribly stressful state, and they're very vulnerable because usually you've done your your first pregnancy exam with them, showed them a little picture of their 8-week fetus with a heartbeat, and their emotions are very conflicted, and it's very difficult. And I think that's why men don't carry babies, except for that one that had surgery when they were younger. I saw that in the news. I don't know if anyone else did. But so I think it is a hard time, and I think it's hard for patients, and it's very difficult to keep up. Many of my patients cannot understand, I said, percentage ratios. They told my other daughter, as I said earlier, and it never had that. It's like a bed bug-like infestation with good intentions, but missing the big picture. I want you to get me maternal blood, cord blood, newborn heel stick, and I'll find out what we'll have. And that's a question I've been asked. Now that this stuff is coming to fruition, people are coming out of the woodworks, and I didn't know. I have the medical geneticists who clinically operate. I have my genetic counselors who actually get along with the most. And I have the people who are coming out of the labs who are just coming over and setting up appointments all day long, want to meet with my fellows and I. Can you get me baby's blood? Can you get me fluid? Can you get me mom's blood? And then when you start saying, okay, what do you want this for? Because we're going to have to get an IRB, and we're going to have to justify what we're doing. Oh, no, just get in. They're really the mad scientists in my mind. I don't say that about Diane Bianchi. She'll kill me. But they'll come and they'll go, I want this because I can go ahead and I can shotgun sequence the whole DNA. I go, and I'll look for different weird repeating segments. I go, well, I think if we look for schizophrenia, Kirk, I think if we look for schizophrenia, we might have a test to predict schizophrenia. I go, okay, well, I'll be dead in 45 years. So who's following up that they actually got it? And number 2, if you tell a mom your baby's going to get schizophrenia when it's 35, 38, is that a good thing to do? I guess we're going to maybe then really get it earlier. I don't know. But you wouldn't believe the people, now that this is hot, coming and saying, can you get me, it's just blood, just get me some blood. Oh, could you talk to the governor and see? I go, I was on a March of Dimes committee. I don't talk to the governor personally. I just was on the committee saying we need to do the newborn screening because it's saving a lot of kids from PKU and stuff like that. Well, but could you get those heel spots for us? I go, okay, the lady who goes there with the big troop of people who don't want that testing because they think we're controlling the population, that's only going to be more fodder for her if you go looking for schizophrenia on heel sticks. Come on, you know? And so there are some crazy things, and with that, I think I'm almost done. So just like the new knowledge we have about HPV and cervical cancer has changed management, right? I think it's saved a lot more. I see less of the cervix that's flush with the body of the uterus that doesn't exist anymore because someone was just going away for HPV. And I think as we learn more, hopefully we'll get better at it. Maybe we'll test less people because we don't have to invasively test, and maybe it'll all end up being okay. And that's the Rayman thoughts, because everyone always calls me Rayman. So just like the new knowledge we have about HPV and cervical cancer has changed management, right? I think it's saved a lot more. I see less of the cervix that's flush with the body of the uterus that doesn't exist anymore because someone was just going away for HPV. And I think as we learn more, hopefully we'll get better at it. Maybe we'll test less people because we don't have to invasively test. and maybe it'll all end up being okay. And that's the Rayman thoughts, because everyone always calls me Rayman. So just like the new knowledge we have about HPV and cervical cancer has changed management, right? I think it's saved a lot more. I see less of the cervix that's flush with the body of the uterus that doesn't exist anymore because someone was just going away for HPV. And I think as we learn more, hopefully we'll get better at it. Maybe we'll test less people because we don't have to invasively test. And maybe it'll all end up being okay. And that's the Rayman thoughts, because everyone always calls me Rayman. So just like the new knowledge we have about HPV and cervical cancer has changed management, right? I think it's saved a lot more. I see less of the cervix that's flush with the body of the uterus that doesn't exist anymore because someone was just going away for HPV. And I think as we learn more, hopefully we'll get better at it. Maybe we'll test less people because we don't have to invasively test. And maybe it'll all end up being okay. And that's the Rayman thoughts, because everyone always calls me Rayman. So just like the new knowledge we have about HPV and cervical cancer has changed management, right? I think it's saved a lot more. I see less of the cervix that's flush with the body of the uterus that doesn't exist anymore because someone was just going away for HPV. And I think as we learn more, hopefully we'll get better at it. Maybe we'll test less people because we don't have to invasively test. And maybe it'll all end up being okay. And that's the Rayman thoughts, because everyone always calls me Rayman.